on behalf of Indian Academy of Pediatrics, Navi Mumbai. As you know, we are celebrating Rational Antibiotic Awareness Week. So on this occasion, we are discussing common dilemmas in rational antibiotic use, and to get some pulse of wisdom, we have two stalwarts in pediatric infectious disease with us, Dr. Vijay Yewale sir and Dr. Dhanya Dharmapalan madam, who have practiced and nurtured rational antibiotic practice in the country. So I welcome you, sir. Welcome, ma'am. So get ready. Sir, first question for you. How do you go with a fever management in first 3 days of illness?
Most of the times, the cause of fever is an underlying infection. However, not all infections are bacterial infections. And clinically, it is not so very difficult to differentiate a bacterial from non-bacterial infection. So that is the first thing that one must remember. And if you ask yourself a set of questions, then one can definitely be rational in approaching a child with fever. First, document the fever. If there is a confirmed fever, try and find out if it is a bacterial or non-bacterial fever. If it is a bacterial fever, just give it a thought whether I can avoid using an antibiotic. Is it a self-limiting bacterial infection? For example, a mild otitis media, unilateral, in a child above the age of 2 years, one can easily wait for at least 48 to 72 hours before starting an antibiotic. And the third question is, after having decided to use an antibiotic, ask a few questions. What is the likely organism or pathogen causing this infection? What is the site of the infection? How severe is the infection? And am I likely to come across the pathogen with bacterial resistance? And is there any host comorbidity to decide use of an antibiotic? So unless you have these questions answered, don't think of writing an antibiotic. And remember, in outpatient practice, in a child who presents with fever, try and use first-line agent and use a single agent and allow it to act for at least 40 to 72 hours before you revisit the patient and revisit the diagnosis.
Thank you, sir, for such an elaborate answer. Ma'am, what are the most commonly used antibiotic in general pediatric practice?
Fortunately, most of the consultations in pediatric are for symptoms like fever, cold, cough, vomiting, loose motions, which are most commonly caused by viruses. So for antibiotics, there are very limited conditions. So I'll just enlist some of them. One is if there are exudates in the throat, amoxicillin is the first choice, but please note that the dose is 50 mg per kg per day given for 10 days. Then for suspected bacterial infections in the chest, like LRTI, then it is amoxicillin or co-amoxiclav, and in age above 5 years where mycoplasma can be a possibility, azithromycin. Even cefpodoxim can be used for bacterial infections. Then for typhoid, we give cefixim or azithromycin, but the dose is 20 mg per kg per day for a proper duration of at least 14 days for cefixim. Then, but it should be after sending blood for blood culture. Then for urine infection, again, one must send for urine culture, but one can start empirically while waiting for the culture reports, cefixim. And then for otitis media, again, amoxicillin is the drug of choice. In certain situations, co-amoxiclav can also be given. And for dysentery, azithromycin or cefixim are good choices. So these are the common antibiotics.
Sir, which are the antibiotic which should be totally avoided in general pediatric practice?
So as just now Dr. Dhanya said, there are very few situations in outpatient practice where an antibiotic is required. And she enlisted only a few antibiotics. I think any antibiotic beyond this amoxicillin, azithromycin, cefixim or cefpodoxime are hardly required in your a patient who comes with acute febrile illness. So unless you make an attempt to establish a definite diagnosis, one should not use antibiotic in community-acquired infections and try and use the first-line agent. And answering your question specifically, which should be avoided, one is broad-spectrum antibiotics, irrational combinations should be avoided, and no child should receive an antibiotic unless you suspect a bacterial infection after sending the relevant test to establish the diagnosis. And there are very few situations where an antibiotic is required at first visit in a febrile child.
Ma'am, why antibiotic stewardship should be followed?
To answer that, what is antibiotic stewardship? It is basically using antibiotics responsibly. What means responsibility is in the correct 5 Ds, the right drug, in the right dose interval, in the right duration, and in the right delivery. That is whether it should be rightly oral or parenteral. Now, it has been shown with sufficient evidence that if you follow antimicrobial stewardship, then it improves the clinical outcome of your patient. It reduces the chance of increasing resistance in the community. It reduces hospital costs and hospital duration for the patient. And lastly, it also decreases the adverse effects that come with unnecessary use of antibiotics. Antimicrobial stewardship, when one talks about and hears about, one thinks that it is probably only in institutions. No, it is not. Every individual can practice in their clinic. The 4 components are commitment, practice policy, tracking, and education. Commitment for antimicrobial stewardship should be a daily commitment. One should be daily committed for rational antibiotic practice. For action policy, one can refer to evidence-based guidelines which are easily available by the Indian Academy of Pediatrics, by national guidelines, international guidelines. WHO has come out with a very good book called as for common infections based on AWARE classification, that is access, watch, reserve, where it has been, all antibiotics have been classified as per their resistance potential. So they recommend that most of the OPD practice should be from the access group, like example, amoxicillin, co-amoxiclav, so where the resistance chance is less common. Thirdly, tracking. How do you track? Most of us are using electronic records. So one can look at the last month's data. Where have I used antibiotics? Whether it was necessary. And also peer review, or in group practice, usually it helps when you discuss. So that way you can track. And lastly, education. One must keep updated with the latest, what's happening, attending the conferences, as well as educating the patients during counseling about proper use of antibiotic, proper reconstitution, to not resort to self-medicine, medication, etc.
Thank you, ma'am, for such a structured explanation. Sir, where you use antibiotic most commonly and rationally?
See, if you look at the conditions that we come across, and given the constraints of availability of labs, majority of times we resort to empiric antibiotic therapy. Though empiric, one can definitely be rational. Now, if you sit and look at the kind of patient that one sees in outpatient practice, there are a few situations where one can go ahead and use antibiotic, even asking for a test. Just to give you an example, you have a patient with acute suppurative lymphadenitis, or a patient with acute dysentery, meaning thereby gross blood and mucus in stools. One need not really ask for any lab and use an appropriate antibiotic. Then there will be conditions where the given infection or the given child that you are examining or seeing is likely to have an underlying bacterial infection. In such situation, you must send the appropriate test, try to establish a microbiological diagnosis, and pending the results, depending on the child's condition, one may start an antibiotic. Now, where do we do this? Say, for example, you have a child where you diagnose a clinical pneumonia, or you have a child who has some urinary symptoms and urinalysis has shown some significant number of pus cells. So you would obviously send urine culture and then start an antibiotic. Then there is a situation where dealing antibiotic therapy may harm the child and adversely impact the outcome. Say, for example, a neonate who comes with fever. One would definitely like to send a set of investigations and pending the results start an antibiotic and then tailor the therapy as per the results which are made available. Either you continue, narrow down, escalate, or even stop antibiotic depending on the result that you get and the diagnosis that you make. And then finally, you have situation where you start treating a child as an underlying viral infection, but the child does not respond as per your expectation, and where you suspect complication. To give you an example, influenza is a benign illness. Child starts becoming afebrile on day 3 or so. One who is becoming afebrile again starts developing fever, has some respiratory symptoms. You suspect an underlying secondary bacterial LRTI. Then one is justified in using an antibiotic. Now, barring this situation, there is hardly any situation where one needs to resort to antibiotic therapy. And as I said before, when you decide to use an antibiotic, think of the probable pathogen, site of infection, severity of infection. Are you expecting a resistance upfront? And is there any host comorbidity? If you think of these things and adhere to the 5 days told by Dr. Dhanya, you will be rational most of the times.
Thank you, sir. Ma'am, is there any problem of antibiotic resistance with the use of local or topical antibiotics?
Yeah.
That's a very good question, because hardly local and topical antibiotics are discussed in the background of resistance. But it is true that irrational use of topical antibiotics are causing resistance. For example, irrational use of fusidic acid or irrational use of mupirocin, which is actually an anti-MRSA agent. So when there is cut, abrasion for simple wounds, instead of antiseptics where povidone iodine is what is necessary and enough, there is a tendency to prescribe mupirocin, which is actually an anti-MRSA agent, and you do not require mupirocin for such wounds. So one must remember that, because agents like mupirocin is the only agent we use critically for decolonization of MRSA, and you can imagine the resistance developing to mupirocin. So please use mupirocin only when you are strongly suspecting MRSA, and especially in MRSA colonized patients. Then again, not just antibiotic, even antifungals, topical, are misused, and especially when they are given in combination of steroids. Nowadays, we are seeing resistant fungal infections on the skin, then requiring oral antifungals. So we must use topical antibiotics also rationally.
Thank you, ma'am. Sir, which is first-line antibiotic in your IPD practice?
So, fortunately, most of them, the acute febrile illness that we see in outpatient are viral illnesses. So, no antibiotic is required. And once I see a bacterial infection, make a clinical diagnosis of a possible bacterial infection, there are a handful of antibiotics which are usually required. They are first-line agent. Like say amoxicillin, your acute otitis media, acute bacterial pharyngotonsillitis, even acute pneumonia can safely be treated with and effectively be treated with amoxicillin. Then you have, say, antibiotic like third generation oral cephalosporins, which can be used, say, cefixime can be used once you suspect enteric fever, and after sending the relevant investigation, one could use cefixime in an outpatient basis, or when a patient of enteric fever is discharged. You can use azithromycin, but I must warn here that azithromycin is something which is rampantly abused given the dosing convenience that one has and the prolonged post-antibiotic effect. One must refrain from using azithromycin, irrationally. So we need to spec. And on very few occasions, one needs to use a combination antibiotic in managing an acute febrile illness. Unless you have a child who is hospitalized and where your underlying investigation suggests that this could be a complicated infection or a hospital-acquired infection. In inpatient setting, the first-line agent which is usually used for a community-acquired bacterial infection is injectable ceftriaxone or cefotaxime, depending on the age of the child. Agents like piperacillin tazobactam should be reserved for nosocomial infections which do not involve the central nervous system. Of course, if one has to use an antibiotic to an underlying CNS infection, your beta-lactam combination like piperacillin tazobactam may not cross the blood-brain barrier. In such situation, one may have to use antibiotics like carbapenem. that is meropenem. So these are a few principles that one must keep in mind while making use of antibiotic. And finally, I would definitely say that many of us are forgetting the antibiotics, which are very often called orphan antibiotics. Let's say cotrimoxazole. It's an excellent agent where indicated. Please have faith in this simple antimicrobial agent.
Thank you, sir. Ma'am, do you feel use of higher antibiotics like ferropenam, linezolid is justified in general pediatric practice?
Well, these higher antibiotics may be justified in limited conditions. Now let's talk about ferropenam. Ferropenam has a broad spectrum. It covers gram-positive, gram-negative bacteria, but it belongs to penem group of antibiotics, and its use is associated with cross-resistance to carbapenems such as meropenem, imipenem, etc. And therefore, especially in our community where we are also seeing carbapenem resistance, we must strictly use ferropenam only in very limited conditions, and there are very extremely limited conditions, I would say. Maybe say a urinary tract infection which is where the isolate is resistant to almost all antibiotics and only sensitive to ferropenam, which you can give orally. Other than that, generally it is not recommended. Now, linezolid is anti-MRSA agent. It works for drug-resistant Streptococcus pneumoniae as well as vancomycin-resistant enterococci. It is a drug which is used for multi-drug resistant TB. Therefore, it is our responsibility to preserve this antibiotic as much as possible and not use it unnecessarily where MRSA is not suspected or detected. So definitely these two antibiotic use must be controlled.
Thank you, ma'am. Sir, do you feel any chapter or curriculum for postgraduate should be added for postgraduate or undergraduate studies in medical studies of all pathies?
Well, as far as allopathy, we do have pharmacology taught in a different way. Maybe a clinical case-based approach would definitely help the students after having learned their basic pharmacology in a very sound way. This can be achieved in clinics, say during their internship or when they do their post-graduation, where a syndromic approach can be, inculcated and rational use of antibiotic can be taught to this. Because the impressions which are made in these young minds, they remain for a long time. As far as other pathies are concerned, Government of India has already included a short course in pharmacology for non-allopathic courses like homeopathy and Ayurveda. And I would strongly urge all those who are non-allopathic, who are into general practice, it is worth spending a few weeks or months at an institution and get a hang of rational use of antibiotic. That would go a long way in preserving this antibiotic and curbing the ever increasing rates of antimicrobial resistance.
Thank you, sir. Thank you, ma'am, for such a wonderful pulse of wisdom. Thank you.
Thank you.
Thank you.